So, in 2011, we have reported a single institutional data of the surgery, radical surgery for initially unresectable pancreatic cancer. It included 12 patients with PDAC, including 8 URLA and 4 URM. And it's achieved 5-year survival, whereas 50%. It is really a start of the surgery for the unresectable pancreatic cancer. Last year, we also have reported for the consecutive 34 patients of radical surgery for unresectable pancreatic cancer. And it revealed that unresectable local advanced ARLA patient, the median survival time is achieved 7.5 years and is better than that of the URM patient. It means that the URLA patient is a candidate, a good candidate, better candidate for the conversion surgery. So we defined the conversion surgery as radical surgery as one of the options during non-surgical treatment, and it is for the patient with initially unresectable and with long-term favorable response to non-surgical treatment. And we, in the early days, we think that the patient who underwent the conversion surgery should be followed by the non-surgical treatment again. But actually, realistically, the patient now have adjuvant chemotherapy of 6 months, same as the patient with general pancreatic cancer surgery. So today I would like to talk about the outcome of the conversion surgery for initially unresectable pancreatic cancer, PDAC, and due to local advancement, URLA, and also about the strategies for management of major arteries and plexus in conversion surgery for artery-related URLA PDAC. So the cohort includes 32 patients who underwent conversion surgery in institute during the last decade. And the woman is dominant, and the age was 45 years in median. And the diagnosis of UR is determined by the NCCN guideline to 2018. So we determined the candidates of the conversion surgery of the URLA patient. The patient having with long-term favorable survival response means SD or PR or CR to non-surgical therapy for 8 or more months. And patient could be achieved arterial resection by radical surgery, even with arterial resection and reconstruction if necessary. So the tumor location is distributed equally in head and proximal or distal pancreas. The UO factor, all the patients had artery-related UR factor associated with 6% of PV-related factors. As for the preoperative treatment, the chemotherapy was dominant rather than the chemoradiotherapy. And the duration of the preoperative therapy was 11 months in median, and 72% of the patients were judged as a partial response in a RECIST guideline. So this slide shows the effect of the non-surgical treatment before conversion surgery. The size of the tumor was decreased in 47% in median, and normalization of the CA99 was achieved in only 64%. The image findings revealed that the improvement of the artery functions achieved in 94%, and but rarely disappeared. So we classified the arterial factor into 2 degrees according to the Japanese classification of the pancreas cancer. The one is nerve plexus invasion, and another is arterial wall invasion. This scheme showed that 2 procedures of the tumor excision besides artery. When the nerve plexus invasion is not circular, we can dissect the total nerve excision and we can preserve the artery. And the artery wall invasion over the proximal, plexus invasion is circumference. We should resect the artery with concomitant with the tumor. But the condition was occurred in SMA. We abandoned resection as our surgical policy. So more concretely, we can detect the arterial encasement. The artery should be embedded, artery wall should be embedded, and we decided to divide the artery, resect the artery. And when the encasement was not exist in the preoperative image study, we could do a frozen section of the nerve plexus. And when that result was cancer positive, we should resect the artery. And the cancer negative, we attempt to preserve the artery by excise the nerve plexus. So this is a flow diagram of selection of operative procedures. Among the 32 patients with URLA, the 30 patients revealed that artery positive or plexus positive. And in the 30 patients, we can preserve the artery in 14 patients. And one patient, including in this patient, one patient is firstly, in the first operation, the plexus around the SMA is positive. We abandoned the surgery, and finally, after the additional chemotherapy, we can finally achieve the conversion surgery. This is a case of the patient who underwent 2 surgeries. This patient, this gentleman, received a long time of chemotherapy, but in the first surgery, the SMA plexus was positive for the circumferences. And after that, the patient at the new regimen, GNP, and after the second chemotherapy, the patient could be dissected by the conversion surgery. The plexus of the around the SMA was free of the tumor. You can see the CT findings of the just before the second surgery. You can see there is some density or high density around the SMA, but there is no tumor actually revealed in the pathological diagnosis. It is very difficult to detect the pathological diagnosis by the preoperative image study. So this is surgical result. There is many types of surgery, and the arterial resection was underwent in 50%, and portable resection was performed in 84% of the patient. And post-operative complications frequently occurred, but the severity was not so high. And all patients are discharged without mortality. The post-adjuvant therapy was given in over 80% of the patient, and time to initiation of the adjuvant therapy was 54 days after the surgery. The pathological findings reveals 90% of the patients achieved arterial resection, and there is no R2 resection. The Evans grade the 2B or more having a 2B or more Evans grade was more than 50% of the patient. So this is a survival curve of the patient. It is the patient of the entire cohort of the patient achieved 5-year overall survival of 60% after initial treatment, or 45% after the conversion surgery. Also, there is a recurrence in 12 patients, but the result of the survival curve is rather satisfactory. So this is a survival analysis according to CA19-9 normalization. You can see that there's a no relationship between the patient with or without normalization of the CA19-9 level. And this is survival analysis according to Evans grade. The Evans grade 3 or more patient or surprisingly high prognosis. And survival analysis according to the in the AR arterial resection group with or without arterial or plexus invasion. The patient with arterial invasion positive or plexus invasion positive patient has a poorer prognosis than those who had not arterial or plexus invasion. So this is the conclusion. Conversion surgery for URLA must be an important option in the multimodal therapies, and especially for a patient having remarkable pathological effect to pre-surgical treatment. And I think the more powerful regimen before and after conversion surgery should be established for the patient who have persistent arterial or plexus fractures. Thank you for attention.
Okay, thank you, Professor Hirano. Any question or comment? Okay, please.
Hi, I'm Marimino Kinusun. I'm a pathologist at MGH. And great talk. Actually, you mentioned that you use the frozen section in order to determine the resectability intraoperatively, right? And how would you sample the tissue from the nerve plexus? Because after the neoadjuvant therapy, you can see fibrosis a lot. Whether you can see the tumor, I don't think so. So how would you sample the?
Yes, it is very difficult to take a sample from the arterial plexus, but we can, firstly, we can tape the artery, and we should do the frozen section from the small, from the surface of the plexus, and next to, and we continued 2 or 3 times to dissect the plexus and to go to the adventitia of the artery. So it is a little bit difficult, but we can do the frozen section after or even after the chemoradiotherapy.
Yeah, so I think probably from the pathology perspective, especially at the time of the frozen section, it's very difficult for us to differentiate the degenerative tumor cells or something else. So we are not confident that we can provide the great information to determine the resectability intraoperatively. That's from the pathology perspective.
Okay, thank you. Okay, so final question.
Good morning. Antonio Mendoza from El Paso. Congratulations, very impressive technique. How long after the last cycle of chemotherapy do you operate on these patients? And do you have a special nutritional regimen you put them on to have them in an optimal shape for them to undergo a surgery like that?
The first one is we have an interval time after the chemo or chemoradiotherapy over 3 weeks. And please, next question.
Okay,
Say again.
The next question is, how do you keep them? Because when you give patients chemotherapy for a while, they have all the systemic effects and their nutritional status gets worse. And the surgeons at my institution have an issue with the fact that they deteriorate nutritionally and the outcomes of the surgery are not going to be good. So if you're giving them chemotherapy and then they go for conversion surgery, do you have any special regimen to keep a good nutritional status of those patients at the time of surgery?
Yeah, there's no, we have, actually, our data was collected in 10 years. So there's many different kind of chemotherapy was used in this data. But now we try to new regimen to do the preoperative therapy, but we have no definitive words.
Just one short comment. I noticed in your series that you treated neoadjuvantly for 11 months, which I think is kind of an outlier duration of pretreatment. I'm just curious how you picked that amount of time. How do you decide the duration of neoadjuvant treatment in your cohort?
This is based on the data from the Japanese nationwide survey. The paper collected just 60 patients in Japan, and the duration of the preoperative therapy is over 8 months is better than those less than 8 months. So we decided 8 months is the minimal duration of the preoperative
8 months
therapy.
minimum. And we'll get Dr. Koh to comment on his thoughts on this question as well. Thank you very much.
Thank you.
Thank you.